All right, everybody, welcome back from our break. As usual, please remember to turn on your cameras, as we not only want to use this as an engagement opportunity, but it is part of getting your CRC credits or the requirements from CRCC to receive your credits. So we are going to be taking questions throughout the presentation. So if anything comes up, feel free to put them in the chat or to just raise your hand and we will call on you. I think that is all of the little announcements. So without further ado, I'd like to introduce Dr. Taylor Williams, or today she is Beauty and the Beast Belle. She's a pediatric audiologist at Arkansas Children's Hospital in Jonesboro. She specializes in amplification and auditory evoked response testing. In addition to working in a clinical setting, she contracts with many schools to serve children in their academic setting. Through her work with Arkansas Children, she has had the pleasure of working with Arkansas Rehab to bring better communication access to children across their lifespan. Dr. Williams, ARA is happy to have you here today. And with that, please take it away.
Good morning, everyone. I'm really excited to get to join you today and to share a little bit about what I know regarding hearing loss and assistive technology.
We
So
cannot
thank you so
hear
much.
you.
Oh no.
We heard good morning.
Oh, you heard good morning and then it cut out.
I can hear.
Yeah, I can hear. Okay, everybody can hear?
I can.
Okay.
Yes, I'm here.
Okay. Well, again, excited to join you with your conference today and share a little bit about hearing loss. So there we go. So I want to start by, just kind of giving you a brief overview. The auditory system is very complex in how it functions with the anatomy and the brain. And so just wanted to give you a brief overview about how we hear. Sound transfers into the ear canal and causes that eardrum to move. When the eardrum moves and vibrates, it vibrates at different levels depending on the type of sound. And those vibrations kind of move through this middle ear space here. I don't know if you can see my cursor, but it's going to move through that middle ear space and jiggle all those bones around. And so when those bones move, what they do is they cause fluid in the cochlea. That's kind of the cinnamon roll shaped piece there. It's going to cause fluid in the cochlea to move throughout that space. And what that does is that fluid creates an electric charge, and that charge stimulates the auditory nerve, and the auditory nerve takes all that electric charge, all those vibrations, and it sends the message to the brain. The brain is actually the piece of anatomy that's going to decode the message. So I think that's something really interesting when we think about hearing is when we think hearing, we think ears. Well, our ears are really just a tool to transmit sound to the brain. The brain is actually the piece of anatomy that decodes those vibrations and that potential energy, and it kind of makes sense of it for us. And so that, being said, the anatomy that's there works in congruency with the brain. The brain is really kind of our hub for decoding and understanding communication. It's the thing that creates those sounds into recognizable and meaningful pieces of information. So what causes hearing loss? Hearing loss typically occurs when sounds that are loud become softer and less intelligible. This is a result of our brain being misled through a loss of audibility. Information also becomes distorted as it reaches the brain, disrupting the quality of our hearing. So this really goes hand in hand with what we know about hearing loss, and that it varies in type and degree. There are people with normal hearing that experience auditory difficulties. If you're in a crowded restaurant and someone could be sitting directly in front of you and you're seeing their mouth move, and you're just nodding along because you should hear them, but all the other factors that are kind of playing into our ability to understand. Head trauma, neurologic disease, medical disorder, or the process of aging can all result in alterations in the ability of the brain to process stimuli. This can lead to symptoms that reflect hearing loss, like inattention, inappropriate responses, and confusion. Our brain really works with our ears in congruency to process those neural events and turn them into meaningful information. Something that we've kind of experienced globally in the midst of COVID is I think everybody can kind of relate to hearing loss now, in that, if my mouth is covered with a mask, you lose a lot of those key visual indicators that we all rely on to kind of interpret and understand what's going on. I know a big frustration that people talk about when they talk about COVID and dealing with masks is I can't understand what anyone's saying. It's interesting, when we lose that visual cue, we're now losing part of our hearing. And so it's interesting to look at the big picture and see all the different factors that kind of play in and contribute to hearing loss as a whole. There are a lot of risks associated with hearing loss. I know as counselors and working with different individuals with different sets of needs, kind of your job is to pick out and dissect and to kind of anticipate the needs of your clients. And so when you're trying to make appropriate placements and appropriate recommendations, you're looking at the big picture of, all right, outside of X, Y, and Z, who is this person as a whole, and what are the things that they need to be successful with where they are? And so some of the things in terms of audiology that I look at, I don't just look at an audiogram. I don't just look at the X's and the O's on the paper. I'm looking at these other big risk factors, social isolation. Hearing loss has a lot of relation with social isolation, and what that can look like in terms of a placement for an individual is if they're reporting unsatisfactory work performance, discontent with workplace interactions, feelings of loneliness, depression, hearing loss, especially in our older population, in our geriatric population, and even in our middle-aged adult population, can cause a lot of issues with self-esteem, self-worth. When you don't feel like you're connecting and having those interpersonal relationships at work, it's hard to feel that drive to go in every day and do your best. When you feel like you're operating in a bubble alone and those supports aren't there, it's hard to really give your best and to get that buy-in. And I think you probably all have experienced those frustrations when you're really working with a client and you're like, man, I'm really going above and beyond, and I don't want to know what I'm missing because this should be the perfect placement. And that buy-in, that piece of, they don't feel connected, and why do we not feel connected, and why are we not making those super critical relationships? Social isolation and hearing loss play a big part in that. Balance disorders, a lot of the times with hearing loss, whether it's in both ears or one, those individuals are going to experience some balance concerns. And so that's definitely something we have to be aware of in terms of safety and looking at different vocational placements. And, if we're worried about vertigo or any kind of disorder that can result in an accident, definitely something to be aware of, and not always something that persons with hearing loss will report. I think probably a lot of you have seen, you almost have to dig and really cultivate that relationship to kind of get some of that information to come out. A lot of individuals with hearing loss are really hesitant to share, yeah, in the morning when I'm getting up and moving around, I feel really dizzy. Sometimes I lose my balance. They may be worried that will affect their chances of getting placed somewhere, or might negatively impact some of the assistance that they get. And so definitely something that we have to kind of think about as we're looking at the whole picture of someone with a hearing loss. Cognitive decline is really closely tied with dementia and hearing loss. So what we typically see is, especially in kind of our 55 to 75 range, is that when we lose hearing, it's kind of the, if you don't use it, you lose it mentality. And if we have an impaired system that we're not stimulating regularly, and we're not stimulating as a whole, the neural pathways in the brain start to kind of lose their juice. They're not being used. And so they kind of get rusty, and they kind of start functioning the way that they're intended to function. And so that can a lot of times reduce understanding. And when we stop understanding, we stop engaging. When we stop engaging, we stop using what we have. And so you see withdrawal, and with withdrawal, that cognitive decline comes. And so, another big thing that it's a huge risk factor that we have to, as providers and as people in the rehab field, we have to kind of be on top of it to look for those warning signs. Tinnitus is another risk factor that persons with hearing loss suffer from, and even persons without hearing loss a lot of the times will suffer from tinnitus. Tinnitus can be extremely anxiety inducing. A lot of individuals I know that have tinnitus really struggle to work in typical office workspaces because they tend to be really quiet. They tend to have a lot of reverberation, high ceilings, all things that kind of draw attention to that nonstop ringing. It can cause extreme feelings of anxiety, and that in turn can kind of cause other comorbidities, depression, just kind of that hesitancy to go into work or to feel like you have the ability to do what needs to be done. So those are just some big risk factors that we look at. So what are some benefits of amplification? Typically, we're looking at providing greater independence. I think as a whole across the spectrum, anyone who works in any kind of a rehabilitation field, we want our clients and our patients to feel independent. We want them to be self-empowered. And I think that's why we all have that passion, and we're all problem solvers. And we're like, okay, you're saying this, I'm thinking of X, Y, and Z that I think will really help you kind of feel like you have that ownership of self, and you have that independence. And so a lot of the times hearing aids, just having that access, just knowing that, hey, what I'm hearing is what I'm supposed to be hearing, it eliminates a lot of that self-doubt. A lot of the times persons with hearing loss are even hesitant to ask someone to repeat themselves because it's this cycle of, I'm going to say, oh, can you repeat that? They're going to repeat it. I'm still not going to feel confident that I understood what the message was. And I'm too scared to ask them to repeat themselves again because A, they're going to get upset with me. B, they're going to be frustrated and maybe not want to interact with me again. Or C, they might just walk away. And that is a real reality that persons with hearing loss face. And especially when we're looking at our population in the workforce, I think it's so important to kind of have that sense of self and that independence, and knowing that, hey, if I need to go to someone and ask them to explain a job role to me or to go over something with me, I need to know that I'm receiving the information correctly. Improved relationships. Again, when you have independence and you have some of that confidence, your sense of self is going to come out more, and that in turn is going to improve relationships. When you feel assured and you feel confident in what you're doing, you're going to have just a natural ease in your interactions with your coworkers. You're not going to feel timid or as timid to ask, for help, because you're not going to feel that, oh, they're going to think it's because of my hearing loss. They're going to think I can't do the job because of my hearing loss. And so I don't want to ask because I don't want to be a problem. I don't want to draw attention to myself. That's a big thing. And again, with that confidence and independence, it improves work relationships. They want to engage in the social aspect because they don't feel like they're a burden, that every time, well, they're going to think I'm just asking a question, every time I go to them. Again, we see a lower risk for cognitive decline when you have access and that pathway is being stimulated consistently. We see that cognitive decline risk go down drastically. So some different types and degrees. I think, in the time that I've been working in the field of audiology and my experiences that I've had with some different counselors in the rehab field, I think it's really, really confusing to try to dissect out and parse out the different types and degrees of hearing loss, because it's confusing. It's confusing to me a lot of the times, and I do it all day, every day. And so the big thing is there are 3 types of hearing loss, and depending on the type of hearing loss that individual has is going to impact the type of amplification that's recommended. So there's sensory neural hearing loss. which happens in the inner ear. So kind of this triangle here is blocking out that inner ear space. So sensorineural hearing loss usually details problems with the nerve pathway, problems with the inner ear. Sometimes it can even be at the level of the brain, issues decoding those messages. So essentially sound is getting there, but at the point that we're trying to decode what that message is, that's where we're having issues. The second type of hearing loss is conductive hearing loss. And so conductive hearing loss means that soft sounds are going to be difficult to hear. Loud sounds are going to be muffled. And it typically involves this middle ear space here. So when I think conductive hearing loss, I'm thinking anatomical anomalies, like if you have a client that has, we call it microtia atresia, but it's a tiny ear, that is considered a conductive hearing loss. If you have chronic drainage, any kind of eardrum tearing, that's going to cause those conductive hearing losses. Typically can be treated with medical intervention, whether that be surgery, medication, but a lot of the times surgery doesn't always fix it. And so it is possible to have clients that kind of have a permanent conductive hearing loss. And then the third type is a mixture of the two, kind of a combination of sensorineural and conductive, and we refer to it as mixed. So very befitting of the name, it's just a combination of sensorineural and conductive.
Hey,
That
Taylor.
being said, yeah.
Sorry, really quick. We did have a question from Mr. Mike McCohen. Is there more hearing loss from excessive use of earbuds in your experience?
So this is something really interesting, and I'm actually on a study right now. What we're looking at, what we expected, big range was to have this huge age of baby boomers kind of coming in and having just this huge need for amplification. And on the flip side, we are seeing a lot of middle to late teenage years being diagnosed with noise-induced hearing loss. And so what that means is they're spending a lot of time with earbuds in the ears cranked all the way up. And we kind of use a rule of thumb that if we're exceeding a certain level of loudness for a certain amount of time, you're at more increased risk to get noise-induced hearing loss. And so we are seeing teenagers that are having high frequency hearing losses, which is pretty indicative of noise-induced damage as a result of wearing earbuds and blaring music a lot. So there are a lot of studies going on right now that are looking at that. And that's a great question. So if you have teenagers, make sure they're not blaring music through their earbuds all day. Just like there are different types of hearing loss, there are different degrees. And so this chart on the right kind of outlines the range that we look at for what's considered mild, moderate, severe to profound. A hearing loss does not have to just fall into one range. It can kind of start normal and kind of slope down into that profound. It can start in the profound and rise up to normal. It can fall somewhere in the middle. I like to think of it as if you were to take a pen and just kind of make any shape, hearing loss can look like a lot of different things, which is why it's so hard and so critical to really lean on the experience of the person with hearing loss. I've had patients that have identical hearing losses. I mean, point for point exactly the same, but their experience with their hearing loss and how they perceive their hearing loss and how they interact with others is completely different. And so I really, really lean on the experience of my patient when I'm looking at, okay, well, you only have a mild hearing loss, we could try hearing aids. You may not feel you necessarily need hearing aids. You may feel you're getting by, just fine. That response that they give me is critical in a lot of the decision making that I do. So I'm just quickly going to go over kind of some of the typical hearing losses that you see and what they mean in terms of functionality. And so bilateral hearing loss is when you have a loss of hearing in both ears. Again, it can vary in degree and type. A person with bilateral hearing loss is going to experience difficulty with localization, meaning if someone is standing to their right, but they have hearing loss on the right and left side. They might not be able to tell, are they coming from my right or from my left? Even, safety concerns, looking at, okay, we live in a big city and we're using crosswalks. Okay, well, if they hear a horn honk, they don't know if it's coming in front of them, behind them, to the left, to the right. Huge safety concerns to kind of be thinking of. Difficulty understanding speech and background noise. That is a huge thorn for a lot of adults with hearing losses. I wear these blasted hearing aids and I still can't understand speech. That is a big thing. And so kind of knowing and understanding and counseling on, the system's not perfect. Hearing aids are a tool, but they're not a fix it. That rehab piece is so important in counseling. How can we improve the environment? What accommodations and modifications can we make to the environment to improve that access to speech? Difficulty maintaining attention and auditory fatigue. This is a big thing for people with hearing loss. I know I've had a lot of patients share with me that I'm constantly getting reprimanded for not paying attention, but I'm so exhausted. It is really taxing on the brain to sit there and constantly decode and process. The processing time for a person with hearing loss takes longer than someone with normal hearing. And so that might be something in terms of counseling prospective employers that, hey, we have a client with hearing loss and they can absolutely do this job, but an accommodation that they're going to need is processing time. If you ask them a question, give them an extra 10 to 15 seconds to respond before you automatically jump to, hey, did you understand what I said? Give them that grace period to kind of take in the information and piece it together and make sense of it. Again, with bilateral hearing loss, you can have various amplification options. And kind of a jarring statistic is that 1 in 8 people in the United States, 12 and up, have hearing loss in both ears. 28.8 million US adults can benefit from using hearing aids. It's kind of a shocking number. Unilateral hearing loss, I know this is a big one that is confusing. I know you probably all heard the terms cross and bicross thrown around and like, what is that and what does it mean and how are they different? Unilateral hearing loss affects, tons and tons of people. And again, this is one of those instances where you really have to lean on the experience of the client. Some individuals with unilateral hearing loss feel like, I do fine. I don't feel like I need any kind of assistive technology. And many of them do very well without any kind of accommodation. And then there are others that say, I am really struggling. I need something. I'm struggling to localize. I'm struggling understanding speech. I am struggling with auditory fatigue. I need something that is going to help me figure out how to do my best, and what does my best look like? And so again, what we typically recommend in terms of audiologic assistance is going to be a cross. In some instances, we recommend a bone conduction hearing aid, and that's going to depend on the existing anatomy and the type of hearing loss. And again, the decision to fit an individual with unilateral hearing loss is made on a case-by-case basis. I would never, if I got a referral in and I didn't have that person sitting in front of me to ask, I would never make a recommendation just based off of what the audiogram was showing me. And because it's so tailored to the individual, as it should be. Single-sided deafness is a type of unilateral hearing loss. It's when you have a reduction in hearing that's so severe that ear is considered to be non-functional or deaf. It can be caused by a variety of factors. And again, kind of making that decision on whether or not to amplify and what we recommend in terms of amplifying is really made on a case-by-case basis. Just as a little tidbit, some of the things that I look at when I'm kind of making an amplification recommendation, I'm looking at the age of the patient. So regardless of type of hearing loss, a lot of the times based on age, I will recommend a specific thing. And that has a lot to do with safety. When you're looking at babies, you don't want to recommend something teeny tiny that they can put in their mouth and swallow easily. Same with geriatric patients. If you have a client who is struggling with dementia, with cognitive decline, with confusion, anything like that, that can kind of sometimes result in those non-conventional amplification recommendations. And we're looking at family support, lifestyle, the functional hearing. And what I mean by functional hearing is a lot of times individuals will experience a trauma, and as a result of that trauma, there's psychosocial hearing loss. And so that's something that we also kind of take into consideration when making those recommendations. So who really needs amplification? Over 5% of the world's population, roughly 430 million people require rehab to address hearing loss. It's estimated that by 2050, over 700 million people will have disabling hearing loss. My personal practice, and it can vary from audiologist to audiologist, but my personal belief is that anyone with a measurable hearing loss can benefit from amplification. I really, truly believe that everyone's life experiences are different. And because of that, I think the way you perceive your environment, the way you interact with others, it's different. You're not a piece of paper. You're not just the audiogram on the piece of paper. We're looking at the whole big picture and what the needs of the individual are when we're making those recommendations. So what do we do about it? Some common misconceptions regarding hearing aids is that it's corrective. Hearing aids are just like glasses. You go in, they get the prescription for the hearing loss, they fit it, and you're fine. That's not true at all. Hearing aids are going to amplify all the sounds. And so what that means is, yeah, you're going to get that signal of interest, but you're also going to get the refrigerator running, the faucet running. You're going to get the people sitting 3 rows over talking, all those sounds that those individuals are not used to having to process and learn to ignore because they've never had access to it. Now they're getting everything, and it's super overwhelming, and it's not in any way corrective. It is meant to provide access to the information, but that rehab piece is so important. And that rehab piece, what it does is it says, hey, it's okay. I know you're overwhelmed. I'm going to give you the tools to kind of retrain the brain and learn to ignore some of those things that are affecting the message. Okay. As someone who works with clients, ranging from 3 weeks old to 21 years old, I spend a lot of time with families and therapists and school personnel, and really anyone who has an impact on the growth and development of a child. And I'm not in any way saying that we should restrict or limit the abilities of a person with hearing loss, simply that, when we're looking at how do we recommend and what are we going to recommend, we have to look at equity and equality. And so equality would say, oh, we've given them hearing aids, they should have the same access to everything that our persons with normal hearing have. Not true. We have to look at that equity piece. What can we give them to perform at the same level? What are the pieces that they need to complete the same tasks in the same way, that equal access that equity provides? And so for me, that's where the audiologist and the rehab counselor kind of make the perfect marriage, because we're so passionate about those accommodations and those modifications. And so whether that be, additional time with a task, visual cues, extra assistive technology in the workplace, all of those things are going to kind of play a role in how we go about best helping this person.
We've got a couple, some conversation in the chat.
Yeah.
I wasn't sure. There's a lot of people that are kind of asking if like Medicare coverage will cover hearing. I didn't know if you had some personal insight to that or not.
It depends. It depends on what kind of Medicare they have. So I can mostly speak from experience dealing with Medicaid. And individuals with TEFRA in that Medicaid, if it's Part A, will cover everything. TEFRA will cover everything. Medicare is a little bit harder because it depends on if there were pre-existing conditions, meaning any kind of priorly diagnosed genetic or functional, anything like that. Medicare, I believe, and again, I don't work much with the adult population doing pediatrics, but I don't think Medicare covers much. And I think that's why so many of the adults lean so heavily on Arkansas Rehab. And why they're so grateful for a lot of the assistance that they get is because I think they really struggle to find those outlets to kind of help them get that assistance. I do not believe Medicare covers amplification for individuals.
And then just really quickly too, I was wondering, you mostly work with the younger population.
Mhm.
So have you, or is this something you'll speak on? If you've got teenagers or even like early 20s, that increased population you were mentioning that are showing signs of hearing loss now, are there ever kind of the social factors of like being embarrassed of like that age group getting a hearing aid, or is
Absolutely.
it?
Absolutely. A lot of what I do in the schools when I go in is I spend a lot of time talking to junior high and high schoolers. Funny enough, even kids who are diagnosed with hearing loss from birth wear their amplification so well, and then they hit middle school. And then it's like, okay, now, even though my friends that I've had since kindergarten know, I'm feeling very self-conscious about it. And a lot of the times they'll take them off and they'll struggle. And so it's so imperative to equip the family members with the tools to kind of encourage and reaffirm and just own it. That ownership is so important. But it is a big problem. We see a lot of high schoolers, a lot of college age students that just they not that they want to struggle, but that buy-in almost isn't there of, I recognize that this helps me, but I just don't want to. Interestingly enough, something I've been trying this year when fitting teenagers is, hearing aids are amazing now. They do all the things that an AirPod does. And so that's kind of how I sell it. I say, these are just like AirPods. You can stream directly from your phone. You can stream from your laptop. You can watch Netflix all day. No one will even know, and that's kind of just knowing your audience and knowing like, okay, how can we really get that buy-in from this 16-year-old who's never worn hearing aids and doesn't think he needs them, but he's got D's in all of his classes because he can't hear, just working on that piece. But yeah, there's a large population of, probably I would say 13 to 21 that desperately need to be amplified, that probably own personal hearing aids that don't wear them. But were there any other questions?
Not so many questions, just a lot of great conversation, and people are loving your presentation, so keep it up.
Oh, glad. I could talk about hearing all day. I'll try to power through the last 15 minutes. There are several different types of amplification, and again, depending on the age, the existing anatomy, and the needs, is going to depend on what we recommend. A BTE is a behind the ear hearing aid. I'm just going to quickly kind of go over. I feel like you guys probably get these recommendations and you're like, what the heck do all these acronyms mean? What is the difference between an RIC and a BTE? I don't know what that is. And why is one getting one and the other getting someone different? So a BTE is typically going to be for patients younger than 7 years old, or for individuals that fall in that range of severe to profound. I like to think of a BTE as this is like your trusty Cadillac that's going to keep going. It could be run over. It could, it's going to go all day. It's got all the power, everything you need to kind of boost sound for someone with a severe to profound hearing loss. The receiver in the ear, that's going to be more for individuals in that mild to moderate hearing loss range. And the little wire that goes down, that's where the power of the hearing aid comes from. So where the BTEs, the power of the hearing aid comes from the body, this guy, the power is going to come from that wire. And so depending on the severity of the hearing loss, we're able to change out that wire to provide more power. The CIC or the ITE, this is really common in our older population. They're typically going to be ones that are custom made for the ear. In all truthfulness, they don't always provide the best acoustic signal, meaning it's not always going to be the cleanest signal. It's not always the best at, filtering out that background noise, but a lot of the older population typically prefer this type of amplification because it's what they know. And it is discreet in a lot of ways. I would argue that this guy is probably the most discreet hearing aid out there. You just don't see that little wire at all. And whereas I think this piece that goes all the way in can sometimes be a little bit more noticeable. So just something to keep in mind if you have a client that based off the recommendation, they're like, oh, but my buddy has this and I really want that because I feel that it's very discreet. Just some things in mind is that there's probably a reason why we went one way and not the other, and that depending on the hearing loss, a lot of the times the CIC is not an appropriate recommendation. A cross. Okay, so we're getting into the meat, the cross versus the bicross. So cross is going to be, essentially for these individuals that have normal hearing on one side and hearing loss on the other. Okay, so again, all that cross is doing is it's taking the signal and moving it to the side with normal hearing. That's all it's doing. There's zero amplification. It's simply taking the signal from one side, moving it to the other. Okay. Which again, we would recommend this for someone with single-sided deafness if they had a, severe to profound unilateral hearing loss. This is going to be the recommendation that you see for that. The bicross is going to be for someone that has a bilateral hearing loss. And so these are the difference. I think it's really confusing because one side typically is going to have that severe to profound or that single-sided deafness, and the other side is going to have some form of measurable hearing loss as well. And so what that means is we're still taking that signal and moving it to the other side, but we're also adding volume on this side. We're giving that little bit of amplification because this side also has hearing loss. That's the big difference between the cross and the bicross. Bone anchored implant. I do a lot of bone anchored implant on the pediatric population. So it might be that you have some adults that kind of come through that have this different type of technology. It is a type of assistive technology considered to be a medical device because it's intended to be implanted. And so it can look like, if you can see the picture at the top of the little girl, it can be on what we call a soft band, where it has not been surgically implanted. It can be on an abutment, which is the picture of the older gentleman on the left. That abutment is a little snap coupling. It can be on a magnet. So that magnet, rather than snapping in, the magnet is just going to sit on there. And then there's also the Ossia. The Ossia is kind of the newest, latest, greatest thing where rather than transmitting sound through the tightness, so that soft band is transmitting sound because of the tightness against that bone. The abutment is surgically implanted, so it's depending on that tightness to transmit those vibrations. The Ossia is Bluetooth, which is really cool because it is not dependent upon the amount of skull mass. It's not dependent upon the symmetry of the head. It is Bluetooth. So it is implanted. There's a magnet that holds the device to the head. There's an array of electrodes and they talk via Bluetooth. They send the message to the nerve, to the brain via Bluetooth. It's kind of amazing. So you might see some of those as you have maybe some 21-year-olds kind of transition to some adult services. The cochlear implant is going to be that small electronic device. It also electronically stimulates the nerve. There's really strict criteria for implantation, especially for our older population. So they typically go through a pretty rigorous assessment, and it requires a lot of oral rehabilitation.
We do have a question about well, we have a comment from Mr. Byron. In his experience as a special education teacher, there was a disproportionate, I can't talk, diagnosis of MR with students, and most were not that. Do you have any comments about that? Did that make sense? Because I messed it up a little bit. Or Byron, would you like to unmute really quickly?
It's just something I found, with a lot of them, especially with cochlear implants, they just were not intellectually disabled, but it looks like the evaluation always listed them as that. And that might be a weakness of the examiner. I don't know, but I just did not see that in them after working with them, intensely.
Yeah, absolutely. I think that's one of the hard things in our field is that, a late ID, we have to be really judicious almost in looking at. So if I, for an example, if I had a late ID, if I had a baby that, was bilaterally profoundly deaf and we were recommending cochlear implants, I would expect that baby, if they were implanted prior to 12 months of age, to have totally normal speech and language acquisition, to be developmentally normal, barring that there's no other diagnoses. The hard part is when you have like a 3-year-old or a 4-year-old where language acquisition should have already started. And so I think what happens is a lot of times in an attempt to ensure that that child gets services, maybe sometimes our wording is protective. But I would agree with you. I think children astound us every day. And, it's hard for a provider who might see that child once or twice a year to kind of make a judgment on, this is what I think the processing abilities are of this child. And then they just take off and they blow us all away. And it's amazing and wonderful when they're just kind of exceeding any expectation that was ever put on them. But I would agree. I've also seen kids, that I thought, wow, I'm really surprised that they're in, a contained classroom or things like that. But I can speak from experience in that a lot of the times it has more to do with that processing time that it takes and needing that one-on-one instruction, kind of those additional visual and auditory cues that you can't always get in a typical classroom. But that's a great point that you make. Mm-hmm.
And then someone had asked, what's the difference between the BAI and cochlear implants?
So BAI is going to be for a kiddo that has a normal cochlea. So what that BAI is doing is it's still shaking the head. It's going to be for kiddos that have that conductive and mixed hearing loss, whereas the cochlear implant is going to be for a kiddo that has sensory neural hearing loss. And so that bone anchored device, a good way I like to remember it is, our bone kind of encases that middle ear space. So when you set a device on that bone and kind of shake the head, what it's doing is it's physically stimulating the fluid in the cochlea to send that message to the brain. Whereas a kid with sensory neural hearing loss, the bones and the anatomy are intact. It's the cochlea. The problem is with the nerve, and the nerve doesn't really want to take the message and send it to the brain. And so we use those electrodes that kind of go through the cochlea to electrically stimulate. So it's kind of the difference between a anatomical physical stimulation and a electrical stimulation. So just depends on the type of hearing loss that they have. Okay. Some assistive technology that we recommend a lot of the time is going to be FMDM equipment and sound field systems. I kind of briefly in my time that I had left wanted to go over a case that I had recently that I was really fortunate to get to work hand in hand with a counselor on, and we were able to talk and go back and forth and share ideas and really work together to, I think, provide an exceptional experience for that client. So it was a 17-year-old with unilateral hearing loss ranging from moderate severe to severe with unrestricted hearing on the opposite side. So we have a side with a lot of hearing loss and a side with normal hearing. She historically utilized a cross system with very little success, and her complaint was that noise levels and input from her good ear made it really difficult to figure out where sound was coming from. She continued to report difficulty hearing in lecture halls and has begun to feel depressed and discouraged regarding her academic performance. So she had done fine in high school where she had all those accommodations and modifications, and then went to college and, okay, now my 504 isn't covering everything and I'm having a lot of trouble. So what do we do? In that case, do we go back to her in the hearing aid that she really didn't perceive benefit from, or do we try something else? And so in that instance, we tried a Roger system. So a Roger system, again, it's a piece of assistive technology. And she took it and really ran with it. And the Roger is different from a hearing aid in that rather than amplifying everything, the speaker's going to wear a microphone, and the individual with hearing loss is going to wear a receiver, and all they're hearing is that person's voice. So for her, and really not perceiving a need outside of the classroom, that was the perfect marriage of technology for her. So again, thinking of this partnership that we're able to kind of cultivate, and what is the role of the audiologist when working with rehab, and how can we assist each other? The audiologist is the healthcare professional. We know about the technology, and we can kind of help do some problem solving, and we know a lot about how hearing loss relates to communication in different environments, and the counselor is trained in all the other aspects. And a lot of the times the counselors have specialty training to help and understand the needs and abilities of people who are deaf and hard of hearing or deaf and blind, can use American Sign Language, and they know the services to address hearing loss issues in the workplace and guidance on counseling and how to cope with hearing loss. And so I think the best way that we can work together is to just communicate and ask questions and keep each other updated. And so I feel really fortunate to work at Arkansas Children's and to regularly get to work with Arkansas Rehab, and to kind of lean on them and learn more from them, and share ideas, and just really fortunate to get to be a part of a system that uses its resources. So that is all I have today.
All right. Well, thank you so much. We actually have about 15 minutes or so. I don't know
Okay.
if, so just going back, if you had a comment in the chat that you would like to, you can go ahead and unmute and go ahead and put that out there. I don't see a whole lot of questions. I think we covered most of the questions, but go ahead and take this time to either raise your hand or unmute. And if we end a little early, then that's okay. I see a lot of thank yous and you're awesome. So.
Well, thank you guys. I so appreciate you letting me join you today and speak a little bit about something I'm passionate about. So I'm very appreciative of your time.
We did get a question just now from Mr. Shane Bronson. Are there any new treatments for tinnitus or tinnitus?
So technology is evolving all the time, and we're constantly cultivating new rehab strategies. I think that's the big thing with tinnitus is it doesn't go away, and perception is such a big part. And when you don't have the tools to kind of reshape your perspective, it can take over your life, and that anxiety can take over your life. And so audiologists as a practice are constantly researching and looking into new rehab strategies. I think that's the big thing is hearing aids don't fix tinnitus. They provide a substitute almost. And so that rehab piece is so critical, because what we spend a lot of time is retraining the brain to not focus on that sound. Don't focus on, that feeling of anxiety and being upset. Let's learn to refocus our attention. Let's look at some other things. And so it's really focused around retraining the brain, learning to ignore that incessant buzz. There is not currently a medical intervention or surgery, though, that fixes tinnitus.
So I'm sorry, I should have probably asked in the chat first. So I have tinnitus from severe TMJ, and I'm working on getting the surgery for this to correct it. I've been told that there's a possibility with the TMJ correction that my tinnitus might clear up because it has inflamed my auditory nerve. Everything over here hurts. So is that your understanding as well, that there's a possibility there, or?
I will be honest in that is not my typical wheelhouse. but I would imagine, I'm assuming it was probably the otolaryngologist that counseled you a little bit on that. And I would say they are very good about not over promising. And so I think if your provider is counseling you and saying, hey, you know, this is there's a chance that maybe with correction of the TMJ that some of that inflammation goes down and you might notice a decrease in some of those symptoms you're experiencing, then I would hope that they're not over promising in that sense. But I'll be honest in that I don't typically work with many individuals that have had that experience.
Gotcha.
And then Taylor, did you have your contact information on the PowerPoint? I forget. Or
I don't think my email is on there, but I will put my email in the chat and anyone is more than welcome to reach out because I'm not kidding. I could talk about hearing loss and assistive technology all day. So beware, if you reach out, you've made a friend.
well, there's also another question from Shane. If someone starts to stutter, is that a sign of hearing loss, or do you think there's a correlation?
I think that's tricky because hearing loss, the hard thing is that you can be born with normal hearing and you can have something environmental or genetic that triggers a hearing loss, and whether it goes to a certain level and stays there or it's progressive, it's hard to know. And stuttering can be kind of a comorbidity of hearing loss because again, when you have a disrupted auditory signal, trying to reproduce those sounds is hard to do. And that's why we see a lot of kids that have speech delay that are also experiencing hearing loss. And that's kind of a lot of the times the first catch is, hey, we have this speech delay or certain sounds aren't being produced correctly. And we've ruled everything else out. You know, we're just going to check hearing, and then lo and behold, it ends up being a hearing loss. And oh, yep, that S and that SH, they fall in these high frequencies, and that's exactly where their hearing loss is. So when you can't hear those sounds, it's, you know, you can't produce them, which goes hand in hand again with that language acquisition, because we learn to speak from hearing our moms and our brothers and our sisters and our dads talk, and that's where we get our, you know, lexical dictionary is hearing all the people around us make those words and those sounds. So yeah, I absolutely think that hearing loss can contribute to certain speech delays and speech factors like stuttering.
Taylor, this is Kachita. I'm wondering, how does vertigo correlate with hearing loss?
Absolutely. So, gosh, I wish I had my little diagram again. So our inner ear is composed of the cochlea and the semicircular canals. And those semicircular canals are kind of those loops that you typically see, those three little loops. And within those loops, we have intracellular fluid and we have crystals. And those crystals, what they do is they flow through that fluid. So as we move, as I kind of move my head, what those crystals are doing is they're adjusting within that fluid so that no matter which way I move, my eyes are going to stay centered. They're going to be what kind of keeps me in an upright position. It's what helps us if we trip. That's how we catch our balance, is those crystals move and they accommodate for that quick shift in weight and kinetic energy, and they're able to kind of compensate for that. And so for a person with hearing loss, you know, you're relying on all the outside things. So if you have a disrupted system, if you have a part of the inner ear that isn't functioning the way it's supposed to, it kind of throws the whole system off. Similarly to if I were to break a finger, well, it's only one finger on my hand and I still have all these other fingers. I should be able to write. The way I write and the fluidity in which I write and the way that it looks are all going to be affected. So I can still write, it just doesn't look the way it should look. Does that make sense? Okay. That was a great question. Thank you.
Mr. Ramsey asked, are there any adverse effects for a bilaterally cochlear implanted individual not wearing both cochlear implants regularly?
So there are definitely adverse effects. And so what I always caution about getting implanted and not wearing it, essentially when you get a cochlear implant, if you had any kind of residual hearing, and so what I mean is, let's say, okay, in these really, really super low frequencies, you have a little bit of hearing, but for the most part, any frequencies that speech and language or environmental sounds that they fall into are not usable. All right, cochlear implant is a great option. Well, when you insert that array of electrodes into the cochlea, you're taking out any prior existing hearing. So even if there was a little bit of hearing that they were using to kind of be aware of what's in the environment, most of the time that's gone after cochlear implantation. And so what I really caution individuals who get implanted but choose not to wear it is we have to really be diligent about our safety and being aware of the environment. That to say there's nothing wrong with choosing to not wear your implants. If you choose that, hey, my preferred mode of communication is not spoken voice, I primarily use ASL, and I identify with a group of people who don't utilize amplification. That's totally fine. You just have to be aware that, hey, I need to be on top of some of the visual cues that may present themselves in instances where my safety might be a concern. Additionally, if we're not wearing them consistently, our ability to decode the signal goes down. So speech understanding is going to go way down. Again, if you don't use it, you lose it. If you're not stimulating those electrodes that are implanted consistently, you're going to lose that ability to process. The same way that when we get implanted, we have to go through a rigorous rehab process because we're learning a new way to hear. This is a totally different way to hear than the way sound was organically passing through. Totally different. We're learning how to decode sounds differently. We're using a different part of the brain. So when you don't wear it consistently, the brain is really never to adapt and adjust to this new way of hearing. And it makes it difficult to understand speech and language.
So we got a couple more. We've got about 5 more minutes, everybody. There's a question that said, can ear tubes in children lead to hearing loss?
So typically it's not the ear tube itself. It's what we would call a fluctuating conductive hearing loss. And so what that means is you've got a kiddo, from the get-go, they've got drainage and fluid. And so we do a set of tubes and they drain, and then they come back and tubes have come out, and we have gunk again. And so that gunk is what's causing that temporary hearing loss. Okay, so we're going to do tubes again. Great. Ears are draining. Tubes are open, but we continue to repeat the cycle. Well, eventually, because you're punching holes in the eardrum, sometimes the eardrum doesn't heal itself. Most of the time, the eardrum will heal itself when the tubes come out. But, when we look at kiddos who have had 5, 6, 7 sets of tubes and the ears are no longer draining, but we're still having significant difficulty understanding, those tend to be what result in those permanent conductive losses. Where the nerve, the inner ear is totally fine. It's that middle ear space where the eardrum and those tiny bones are kind of working together. And that's where that hearing loss tends to happen for those kiddos. That's a great question.
Just a last comment from Mr. Byron. He just said it's so relaxing when you're able to take out your hearing aid or a cochlear implant, and that's his experience, and his students have told him that. So
I 110% agree. That auditory fatigue, when you spend all day listening and you're putting all your effort into engaging and making sure that you're hearing and understanding and responding appropriately. I tell parents all the time that, hey, if your kiddo comes home and they want to take their hearing aids out for 20-30 minutes, if they want to have snack time without having any kind of stimulation, let them. They need that time to kind of rest and recharge. The brain needs that a lot of the time. So absolutely, I agree with that. Yeah.
all right, well, once again, thank you so much for your awesome presentation. a lot of individuals are commenting about how helpful it's been and informational. And so we will be posting PowerPoints after the conference as well. So her email, she did post in the chat, but if anybody needs that, that hasn't gotten a chance to write it down, feel free to reach out to me. And I hope you have a great rest of your day, Taylor.
Thank you all. Really appreciate it.